Barbiturates are a sedative hypnotic class of medications that can be given to achieve sedation or total anesthesia. Barbiturates are central nervous system depressants that also serve as anxiolytics and anticonvulsants. They are agonists at GABA A receptors, the principal site of central nervous system inhibition. Barbiturates also inhibit synaptic transmission of the excitatory neurotransmitters glutamate and acetylcholine. Tolerance to barbiturates develops quickly, and withdrawal symptoms can be more pronounced than withdrawal seen with benzodiazepines or opioids. Although not extinct, with special applications for various procedures, barbiturates have fallen out of use in anesthetic practice in favor of drugs with more desirable profiles such as benzodiazepines. Currently, some barbiturates are not available in the United States. However, some countries do use barbiturates regularly, and therefore it is important for anesthesia providers to possess knowledge of this drug class. Furthermore, methohexital has found a niche as the drug of choice for electroconvulsive therapy, and it is appropriate for the anesthetist to have a thorough knowledge of the drug and its class. Barbiturates were revolutionary to anesthetic practice in the early 20th century. They represented the first true IV anesthetic. Before the introduction of barbiturates, the use of ether for induction of anesthesia was very dangerous, unpredictable, and slow. The use of thiopental endured for many years as a mainstay in anesthetic practice due to its rapid onset and short duration of action. Barbiturates enhance inhibitory neurotransmitters at the GABA A receptor, specifically the beta-3 subunit. The GABA A receptor is a chloride channel composed of at least 5 subunits with specific sites of action for GABA, barbiturates, benzodiazepines, and other molecules. Barbiturates binding to the GABA receptor enhances and mimics the action of GABA by increasing chloride conduction. This leads to hyperpolarization of the postsynaptic membrane and increases excitability threshold. Barbiturates at low concentrations enhance GABA by decreasing the rate of GABA dissociation with its receptor and increasing duration of chloride channel opening. Barbiturates at high concentrations can activate chloride channels directly, and GABA itself need not be bound. This is termed a GABA mimetic effect and is responsible for barbiturate anesthesia. Barbiturates also block excitatory neurotransmitters. They inhibit glutamate and acetylcholine transmission at the synaptic cleft through an unknown mechanism. Barbiturates have many side effects throughout the body. In the central nervous system, they lower seizure threshold, decrease cerebral metabolic rate of oxygen consumption, decrease cerebral blood flow, and decrease ICP, although cerebral perfusion pressure is preserved. In the cardiovascular system, barbiturates have direct vascular and cardiac depressive effects. Mainly, barbiturates cause direct peripheral vasodilation by depressing the medullary vasomotor center, which then leads to venous pooling. Cardiac output is decreased due to direct negative inotropy from a decrease in calcium influx into the myocardial cells. There is also a transient central nervous system blockade of the sympathetic outflow. All hemodynamic effects depend on the speed at which the infusion is delivered. The respiratory system is affected in many ways as well. Barbiturates as a drug class produce central respiratory depression that is dose-dependent. This effect can be exaggerated in patients with pre-existing lung disease. When used as induction agents, barbiturates have been known to cause what is known as double apnea, an initial apneic episode followed by a few breaths of normal volume, then a subsequent prolonged apneic period. With all drugs in this class, the ventilatory response to carbon dioxide is blunted. Phenobarbital is a barbiturate that stimulates increases in liver microsomal proteins after sustained therapy lasting 2 to 7 days. This increase in liver proteins can lead to accelerated metabolism of other drugs, such as anticoagulants, phenytoin, and tricyclic antidepressants. Heme production is also accelerated. This is the main mechanism behind exacerbation of acute porphyria in susceptible patients. The most severe consequence of IV barbiturate use may occur upon accidental arterial injection. This misfortune may lead to tissue necrosis. Treatment includes diluting the drug at the arterial site with saline, giving heparin to avoid thrombosis, and supportive measures. Other unique side effects include an onion or garlic taste upon injection and rare allergic reactions. True anaphylaxis can occur, but some reactions appear to be anaphylactoid or due to direct release of histamine from tissue mast cells. This can range from a transient rash on the head, neck, or trunk to facial edema, hives, and bronchospasm. Barbiturates are used for premedication, induction, and maintenance of anesthesia. This drug class has no analgesic properties. Most commonly used drugs from this class include thiopental, thiamylol, and methohexital. In premedication, benzodiazepines have replaced barbiturates due to the tendency of CNS effects of barbiturates to persist as a hangover. Rectal administration carries a special set of benefits for use in young or uncooperative patients to achieve loss of consciousness. Induction doses of barbiturates depend on weight, age, and cardiac function. Barbiturates can also be considered as adjuncts for brief procedures like cardioversions and electroconvulsive therapy. Barbiturate coma can be considered as an acceptable treatment to reduce refractory intracranial hypertension after other medical management modalities have failed. It is a general consensus that barbiturates decrease cerebral metabolic rate of oxygen consumption, which then reduces hyperthermic responses to ischemia and prevents seizures. When burst suppression is achieved on electroencephalogram, there will be no further benefit to increasing the rate of a barbiturate infusion. Although this method does decrease intracranial pressure, there has been no significant data that shows decreased morbidity or mortality, and it is associated with severe hypotension. The use of barbiturates is not recommended when a patient has an obstructed or ineffective airway, and further respiratory depression could be detrimental to oxygenation and pulmonary elimination of carbon dioxide. Inadequate ventilation and control of the airway in patients with acute status asthmaticus may be exacerbated by barbiturates. This drug class should not be considered an option in cases of shock or cardiac volatility. Barbiturates may also encourage porphyria attacks. Barbiturates should not be administered without proper IV access or without trained anesthesia personnel and advanced airway equipment present. Methohexital, or Brevital, has found a niche use in anesthesia for electroconvulsive therapy, or ECT. This treatment is used to reduce symptoms of depression and sometimes schizoaffective disorders. During ECT, seizures are intentionally induced. Methohexital is useful in this application because it diminishes the threshold at which a seizure occurs. Methohexital is a sedative hypnotic anesthetic that acts by binding to the GABA A receptors with beta-3 subunits and increasing the affinity of GABA for its binding site. This increased affinity for the inhibitory neurotransmitter increases the duration of opening of chloride ion channels. The net effect is a hyperpolarization of postsynaptic membranes and nerve signal transmission inhibition. At higher doses, GABA itself does not necessarily need to bind, and barbiturates mimic GABA itself. Methohexital can be indicated as a premedication given at a dose of 20 to 30 milligrams per kilogram per rectum. Rectal administration has been proven effective in patients for induction purposes, and sleep onset can be achieved in 14 minutes with per rectum doses of 25 milligrams per kilogram. This can be especially beneficial in pediatric patients. Induction of anesthesia can be done with methohexital at doses of 1 to 2 milligrams per kilogram IV in adults and children, or 5 to 10 milligrams per kilogram IM. Rapid induction and emergence has been noted with methohexital use with doses of 1 to 2 milligrams per kilogram in adults and pediatrics. Methohexital is hypnotic, shows no analgesic properties, is cleared rapidly, and recovery from infusion is similar to propofol. Methohexital can be used for maintenance of anesthesia at doses of 50 to 150 micrograms per kilogram per minute in adults, although this is not a recommended practice. Methohexital has become commonplace for use during ECT due to its ability to lower the seizure threshold. The dose range for this procedure is recommended to be 0.75 to 1 milligrams per kilogram in adults. During ECT, a seizure is induced and the therapeutic effect on attenuating mental disease symptoms is directly related to the duration of the seizure. Thus, by lowering the threshold at which a seizure can be induced, methohexital effectively assists in prolonging the therapeutic seizure. Along with the aforementioned side effects for barbiturates as a drug class, methohexital has been known to produce unique excitatory symptoms on injection. These include cough, hiccups, tremors, and twitching. Excitatory symptoms can be attenuated by pre-treating the patient with opioids. Seizures have historically occurred in neurosurgical patients after large doses of methohexital. Acute intermittent porphyria is a contraindication to the use of methohexital. Other contraindications include hypersensitivity to methohexital. Use methohexital with extreme caution in the elderly and patients with hypotension or shock, anemia, renal impairment, or seizure disorders. Of note, when methohexital is administered repeatedly or for long durations to patients less than 3 years of age or to patients in the third trimester of pregnancy during surgery, the exposure may be detrimental on child or fetal brain development. Methohexital crosses the placenta and can then lead to cognitive or behavioral impairment. These effects are collectively known as pediatric neurotoxicity and have been linked to developmental delays, ADHD, and learning disabilities. Short or one-time doses have not been associated with pediatric neurotoxicity. Risks and benefits must be discussed between the provider and the patient before using this drug or others in its class in these populations. Once a popular medication, thiopental has fallen out of favor and is no longer available in the United States due to controversy over the death penalty and lack of pharmaceutical producers. Methohexital is a must-know drug for anesthetic providers. Electroconvulsive therapy treatments have exceeded the number of coronary revascularizations, appendectomies, and herniorrhaphy procedures. It is for the treatment of severe and medication-resistant depression and mania, schizophrenia, suicidal ideations, delusions, and catatonic symptoms. Methohexital is the gold standard for electroconvulsive therapy. The speed of recovery of cognitive function is similar to propofol or etomidate after dosing with methohexital. Methohexital holds the advantage of decreasing seizure threshold.